Thank you.
Thank you.
So I was asked to come today and talk about stroke mimics, which we'll get into, but you can't really talk about stroke mimics without talking about stroke for a little bit. So we are going to have a little bit of kind of basic refresher up there at the top. If you feel like that's already been kind of gone through at the beginning of the day, I'm sorry, but we'll just hit the basic spots and then we'll get right into it. And then after the mimics portion, we're just going to talk about a couple little diagnostic things that are traps that people really commonly fall into. And I've got a couple bonus slides at the end if we make it, if I'm caffeinated enough to talk fast enough to get through all of the other slides. So I don't have any disclosures. And this is basically everything I just said. So stroke, obviously, you have an ischemic and a hemorrhagic component. The hemorrhagic picture, actually, I used this for a med student lecture once upon a time that showed different types of edema, and it got so many giggles that there was an arrow pointing to the bleed as if you couldn't see it, that I use it for every lecture that I talk about hemorrhagic stroke now, because inevitably somebody in the audience is giggling when they see that an arrow is required here. But obviously the majority of stroke types are going to be ischemic. So we'll go into each of those a little bit. So this is pretty much just your refresher. We're just going to talk about the TOAST criteria. When you're talking about stroke causes, the etiology is that's the main part of my job, right? Anybody can start an aspirin. You know, they made fun of us when we went into stroke fellowship, like, oh, you're just going to the aspirin fellowship, what else is there to do? This is the bulk of what we do, is trying to put the etiologies of these ischemic or hemorrhagic strokes into a box, and then that way we can tell, are we putting them on the right preventative treatments? Are we addressing actually the underlying problem so that we can keep them from coming back into the hospital and having repeat events? So when you look at the TOAST criteria, this is an article from what now is probably considered 1,000,000 years ago. There's probably people in the audience that maybe had birthdays around the time that this came out. But the majority of stroke types and etiology types are going to be either cardioembolism or small vessel disease. I know the patient population out here is going to be fit right into that. Your cardioembolic types, and then your risk factors. You also have your large artery, so your athero, your stenosis or your plaques or both. There's another fourth criteria that's just other, which is pretty much just a grab bag for all of those things that have smaller percentages. And then your undetermined etiology, which if you look at the evidence is roughly 30%. I like to tell patients that that's everybody, and that's not just including places where there's actual specialists. So I would like to say that our undetermined etiology cohort is much, much less than 30%. But that's what the numbers will tell you, so that's what goes on this slide. This is basically breaking down each one of those categories. So if you look at cardioembolism specifically, AFib obviously is going to be your most common thing that you see really often causing strokes. Mechanical valves, anything that can give you a thrombus in an area of the heart that can go up there, whether that's infective, whether that's morantic, and then your severe heart failure, dilated myopathy, basically anything that can cause clotting or cause clotting in areas of the heart that could travel up to the brain. Your large artery athero is pretty self-explanatory in terms of your artery-to-artery findings, which is what we talk about when you have a piece of plaque that's going elsewhere. Obviously also common in this population, or when that causes stenosis. So maybe the moya-moya patients like Dr. Welch talked about, or anybody that maybe just has one area of stenosis that's keeping that area of the brain that it provides blood flow to from getting an adequate amount of blood flow to it, or oxygen to the brain. Small vessel disease is also very common. If you remember the percentages from earlier on, it's going to be your second most common type. So these are the more common risk factors that you think of when you think of vascular risk factors, right? Your diabetes, your high cholesterol, your blood pressure. These tend to be in deeper areas of the brain. As you can see from this picture, it's kind of more towards the middle. So you're kind of trifecta there at the top, and then obviously things like tobacco, a bunch of different illicits are going to fall into those categories. Something like cocaine that can cause vasospasm in itself and raise the blood pressure, and then you have a blood pressure that's really high and hard to treat, so a lot of things can fall into this category. Alcohol abuse beats up on those little tiny vessels. This is also what your brain looks like when you have CADASIL, if you've heard of that before, which is basically just a genetic version of getting all of these smaller vessel infarcts. The other determined etiologies, like I said, are a little bit of everything else. You have a reason to be hypercoagulable, whether that's cancer or you have a clotting disorder, trauma, you've had dissections, whether that's chiropractor or your blood vessels are set up for dissection, vasculitis, spasm from something, and then your cryptogenic or your undetermined etiologies. I told you we're going to blast through the boring part, so we're almost there. So hemorrhagic-wise, blood pressure is going to be your most common cause, also probably what you see a lot over here. Again, in your deeper parts of the brain, high blood pressure, by and large, is the most common bleed cause that we see. But a lot of those other things can also cause it too. Anything that can beat up on your blood vessels, eventually making them more friable and prone to bleeding. So all of your substances are still on this list. Coagulopathies, and then obviously vascular anomalies. Some people will bleed from anticoagulation in general. We'll talk a little bit about CAA in a minute, so I left that off of here. Those are your big ones. And then this is a picture that I always love to use just in terms of percentages. As you can see, B and C are those deeper areas, kind of like that earlier picture. So those are going to be more commonly in those middle areas of your brain where you're getting beat up on from things like blood pressure. Okay, that's it. That's the refresher. You survived. So recrudescence doesn't technically count as a stroke mimic, but I think it's a really common thing. So we should talk about it for a minute. So if you have already had a stroke, whether that was ischemic or hemorrhagic, whether that was a month ago, whether that was 10 years ago, you had symptoms initially, those slowly improved over time, whether they all the way resolved or whether they improved a little bit or somewhere in between with therapy, with time, et cetera, and your patient got to a point where they have a new normal of their symptoms or their symptoms have completely resolved. When you have any stressor on your body, even if it's not related to a neurologic cause, that can cause those stroke symptoms to come back out. Sometimes that's a little bit of a fluctuation in those symptoms. Sometimes they get really severe and it looks like they're having the stroke all over again, which of course to the patient is, this is what happened last time, that's very scary, they come to the emergency room. Now, you still need imaging because you can't necessarily say for sure that it's not a new stroke, right? I can't tell you that all the time. But things that can be somewhat suspicious is if you have the exact same symptoms as before and they're fluctuating and you have another reason. Your labs are all over the place. Your blood pressure is in the 250s. The patient just got over the flu. You have the worst headache of your life. Any of these kind of more common things on there, but it could be any stressor, whether that's on the body or whether that's a mental stressor too. Sometimes people will have a relative pass away and they're stressed, so they're feeling poorly and their symptoms worsen. So the symptoms are going to be exactly the same symptoms that they had with the prior stroke. They may be as severe at the beginning. More often than not, they're going to be some level in between, but there's never going to be new symptoms. If you had left-sided weakness with your old stroke and you come in with right-sided, it's not recrudescence. But if you have left-sided symptoms that were improving with therapy, and then all of a sudden, with all of these other things going on, you feel like you've taken a month, backwards with your rehab efforts, and all of these other things are happening, a lot of times those patients are going to get scanned and are not actually going to have a new stroke. So you scan these people just to make sure, because you want to make sure that they're not extending their prior stroke. But if their imaging is normal, those symptoms, when you address the underlying problem, should slowly improve. So the blood pressure comes down, the hyponatremia gets corrected, et cetera. Those symptoms should slowly go back to their normal. So you see recrudescence a lot, but that's kind of the breakdown of it. So let's talk about a couple individual stroke mimics. So on the left here with the little orange bullets are things that I think don't need a ton of explaining. Obviously, really high blood pressures are going to be a really common cause, especially of more nondescript things like your fingers are tingling, your left arm is tingling. That can come from a bunch of things, right? But it can also make symptoms that look entirely like a new stroke. You can have face, arm, leg weakness. You can have all these other things. Sometimes it's just really high blood pressure, even so high as to have something like press. Blood sugar is a really common culprit. We get a lot of stroke codes to the ED and the patient's sugar is in the 50s or the patient's sugar is in the 750s. Either extreme can do that. Migraines, sometimes you have stroke-like migraine that gives you actually, hemiplegic symptoms, or their migraine comes with stroke-like symptoms. Some people's aura actually can have symptoms that could be mistaken for a stroke, and that's just leading into their migraine. Those you have to establish a pattern for, because the first time you have it, obviously you don't know if it's real or not. So the first times these people are presenting with these things, the scan is appropriate. But if you have somebody that always has hemiplegic migraines, they know what their symptoms are at that point. They know, the patient can probably tell you, when you treat my headache, these symptoms are going to improve. It happens every time. And then other things, of course, on the imaging, like you find a mass or you find something else in the actual brain tissue there. The things we're going to get into a little bit are these black dots on the right, because I have a couple of things to say about each of these, but these are kind of the most common things that I tend to get called to the ER for that don't wind up being strokes. So in CAA, you may have heard of CAA before. Why is it on a stroke mimic page? Just briefly, CAA, if you don't know, is a disorder where basically you have amyloid that gets deposited in your blood vessels over time. Those blood vessel walls get more friable and they're at really high risk of bleeding. So these patients wind up having sometimes bleeds no matter what you do, and will have these typical features on MRI scans that will help us presumably diagnose them. The only way to truly diagnose them is to take a piece of their brain out, which no one is just going to do to diagnose you, but can give you a more probable diagnosis. These patients, they get these microhemorrhages, as you see in the second. So the first one is just saying this is typically what a bleed looks like in a CAA patient. They're not going to be those central bleeds like you get in a hypertensive patient. There's going to be something that's more cortical or lobar. Their imaging will also, on your GRE or your SWI sequences, are going to have these tiny little spots that are typically asymptomatic alone, but they'll have these microhemorrhages that just add up over time. And when you get too many of them, it can be similar to your FLAIR sequence when you have cerebral microvascular disease, in that too many of them, eventually you're going to start to have cognitive fog or memory loss. And so these patients will develop almost what looks like a dementia-type picture often. They're going to be really high risk when you're giving anything that can cause a bleed, anticoagulation, antiplatelets, NSAIDs, anything in those families. So when we see features like this, we tend to tell those patients not to take those things unless they absolutely have to. And then another finding is these on the right side, you see these little squiggles. Basically is the GRE or SWI version of what a subarachnoid hemorrhage would look like on your head CT. You see the kind of the little valleys in there filled with old blood product. The reason that I bring this up in a stroke mimic talk is because CAA has its own particular type of, not TIA, but similar if you think about it in thought process. They're called transient focal neurologic episodes. Most people actually know these as amyloid spells. So in these patients that have CAA, a lot of times they will have episodes that can mimic strokes, can mimic TIAs, can mimic seizures, and are often misdiagnosed. Oftentimes they'll be stereotypical in the same way that you have a focal seizure patient come in and they look the same every time. Some of these patients have that too. They'll come in, they'll have left face, arm, and leg tingling, say, or they'll have weakness of their right hand. It tends to be the same every time. You get the scan, you don't see anything on MRI. Oftentimes people think, okay, maybe it's a TIA. They come in multiple episodes, still don't have anything acute on their MRIs. Some people will call them seizures. In these patients, they actually don't respond to seizure medications. So if you have a patient that has underlying CAA that's had multiple workups for either TIA or seizure, and they're not responding to your Keppra, your Vimpat, et cetera, oftentimes if they have a stereotypical feature to them, then it may be these amyloid spells. They actually don't have treatment. You kind of just watch and they improve. But a good thing to know, because if you have these patients on 4 AEDs because somebody thinks they're seizures and they're not responding, then they're going to have all kinds of side effects for no reason. The thought process is in some of those areas, especially with the superficial siderosis, that, oh, there's a back button, that on the, oh, I haven't used the mouse. Oh, there we go. Okay, I got it. So these areas, these superficial siderosis areas, it's more common in patients that have that because that tends to be a more severe type of CAA. The thought process is that that blood product, even though it's not acute, is irritating and causing the symptoms. If you really get into the weeds in the literature, some people will say there's theories that it's kind of like a 1-second seizure, that there's irritation, but it's not captured on EEG. But you don't see anything on EEG, and they don't respond to anti-epileptics, so most of us don't really think that. But good to know that these exist. The other thing is if you have a CAA patient that has these amyloid spells, it's actually a prognostic factor in that they are at a higher risk of having those lobar hemorrhages than other patients who you just happened upon their CAA on an MRI. Bless you. So seizures, of course, we also have to talk about. I think most people in this room probably know what a seizure is. In general, you've got electrical abnormality in the brain. The first bullet point says causes clinical change. That's not all seizures. That's just a seizure that looks like a stroke mimic. Non-convulsive status doesn't really fit in a stroke mimic talk, but not all seizures cause clinical change, just to clarify. So you can have focal findings or generalized findings, of course. The more generalized seizures, I think, are less likely to be mistaken for strokes. Obviously, if you have a patient that's having a tonic-clonic event and is completely unconscious, most people would not think that's a stroke. But those can have Todd's paralysis, which is when you have a seizure, and then after the seizure, one side of your body is weak, per se, or depending on what part of your brain was the onset of the effectiveness of that. So the after effect, or the Todd's paralysis of the generalized seizure, can often be mistaken for a stroke. And then sometimes the focal findings can also be mistaken for a stroke too. So good to know in terms of other things. This is where your history really comes into play, and that if you have a patient that has, a epilepsy or has had a seizure before, which most, it only takes a couple seizures to be defined as epilepsy, knowing or having a chart that really defines what their seizure looks like can be really helpful, because you also have to think about, you can have a new stroke and a seizure at the same time. It's not very common, but we see it. I had one this week. So you have to make sure that, number one, the patient is waking up appropriately and getting an exam back, and number two, that you hopefully have some type of seizure history or seizure cause, or very clear finding that's not just a negative symptom. If you've got stiffening and, head turning, your eyes are going to the opposite side. So one thing that we use a lot when I'm teaching students and residents and fellows is you look towards a stroke and away from a seizure. That's not 100%. There are wrong way eyes areas of the brain. But for the most part, if you're having, a left MCA stroke versus if you're seizing from a left MCA stroke, your eyes are going to look different ways, and that can be really helpful. So if you remember towards a stroke and away from a seizure, if you have a gaze preference, sometimes that can help. But it's the preceding, if you have a weakness that's Todd's paralysis, if your preceding event was very convincing for a seizure, then that's going to be more comforting than just walking in on the weakness and not necessarily knowing. TIAs, of course, I would be remiss if I didn't say. And then I bring that up, you could call it a mimic or not. A TIA, your body starts to have a stroke and then you wind up not having it. The thing that happens with TIAs a lot, and the reason that I mention it, is because a lot of people use that as a diagnosis of exclusion. They're in the ER, something's kind of funny, the imaging was negative, but they don't really know what to pin it on, so it gets called a TIA. But then it winds up being something completely different. What I like to say, actually, is, and what I ask people commonly when they want to admit somebody for observation for a TIA, is if you had met that patient, most of the time these patients come in and we meet them after the fact, right? They have a story, the story sounds good, you're thinking maybe it's a TIA. In reality, think about if that patient walked in and was having their symptoms, would you have activated you call it a stroke alert here, right? Or a stroke code or whatever you call it. Would you have activated a code stroke? Would you have considered giving alteplase or tenecteplase in this patient? Would you have considered doing a CTA and thinking about thrombectomy in this patient? If it was convincing enough symptom-wise and you can put those symptoms localized to a specific part of the brain, then absolutely. Then it sounds like maybe that's something that started to be a stroke. If it's something more vague, they've got tingling everywhere, they're dizzy, they're a little bit altered, their speech is slurred, but they never had a facial droop. Oftentimes those things are from something metabolic or from something else going on. So think about if you had met that patient when it was happening, would you have thought it was a stroke? If not, you might be kind of barking up the wrong tree there. Also, people call TIAs mini strokes, and nobody really says that anymore, but I bring it up because patients still use it, and the patients themselves don't typically understand, did I have a really tiny stroke? Did I have a transient event that was concerning for stroke? So best to just kind of avoid that terminology altogether. To be a TIA, your symptoms have to completely resolve, no lingering pieces of it. All of it has to completely be gone. And if you look at the definition of a TIA, yes, it resolves within 24 hours. But in reality, the majority of these last minutes. less than an hour for sure, almost all of them. So if you've got a patient that's, been slurring their words for 23 hours and 59 minutes and you're really trying to squeeze that diagnosis anywhere, you probably should be looking for other things. Most of these are 5 minutes long. They were very convincing, and then they're done before they hit the door. They also shouldn't really be having TIAs all the time. Patients come in and they say, I have 8 TIAs a day, and their MRI is clean. A TIA is a warning shot. None of us get that many warning shots, right? You would have had a stroke by now. So the only patients that are going to have actual frequent TIAs are these patients that have terrible blood vessels, these moyamoyas, like Dr. Welch was talking about. If you have a really bad stenosis and every time you stand up too fast and get orthostatic or get dehydrated in the summer, you have symptoms, those are the only ones that I think tend to be frequent. But for the most part, if you're having repetitive events, we're probably looking at a different diagnosis. In the interest of time, because they're already showing me signs, I will skip the anatomy of the facial nerve. I know you're very disappointed about that. But Bell's palsy is another one. Now, there are caveats to Bell's palsy. So Bell's palsy, is just a quick refresher, is your full face and no other symptoms. You have full facial weakness. Typically, it's going to be from a viral infection. There are caveats to that in that if you hit the nerve really, really, really distally, you can actually get a partial face. I will say I've never seen that in real life. Or you can actually hit the facial nucleus in the brainstem and get the full face from a stroke. So something to not forget. But for the most part, your Bell's palsy is going to be a full-sided facial weakness, and a lot of times you'll have other symptoms with it. Not just the eye drooping, not just the face drooping, but you'll have changes in taste, or you'll have sensory changes, or something will feel funny on that side of the face. Typically, that just kind of improves with time. If you come in, within a week-ish, most people will give a short burst of steroids. You can actually look for this on MRI if you have a patient that has maybe really tight vertebral arteries and you have reason to think they could have something in the brainstem. Some people will MRI just to be safe. Like my residents, after we had 2 facial nucleus strokes in 1 week, and then they never trusted a Bell's palsy again for the rest of the month. But you sometimes can actually see the facial nerve light up just with that irritation on MRI. For the most part, clinically, if you don't have reason to think they're going to be stroking in the posterior circulation, you should be okay. This is a whole grading scale just to say most of the time you should try the short burst of steroids to improve this. You don't always have to give the antiviral, but there's a severity scale, and the gist of this is if the Bell's palsy is really severe, you should also give the antiviral. Just a 7-day course of valcyclovir is what UpToDate will tell you, or whatever resource that you use. But that can be helpful in terms of trying to speed along that recovery. TGA is another thing we'll talk about really quickly, or transient global amnesia. So basically, these patients will have an acute onset of anterograde amnesia. Sometimes there's a little bit of a retrograde component, but most of the time it's anterograde questions. So they come in disoriented, they have no idea what they ate for breakfast, they are repetitively asking questions about what happened today, what happened today, what happened today. So obviously the family is concerned. Their immediate recall is typically fine, but anything past that tends to get a little bit blurry. This also tends to resolve within that day, oftentimes within a couple hours, and doesn't really necessitate any kind of treatment. And sometimes can light up on an MRI. I think I have a picture on the next slide. Sometimes you'll have the hippocampus light up. For the most part, your MRIs, most of the time, your MRI is going to actually be negative. So for this, you look for other causes of basically transient altered mental status. So sometimes if you have if there wasn't somebody near them and you're missing a portion of time, you want to make sure that they didn't have a seizure. So maybe an EEG is appropriate. Some people will admit these and do a full TIA workup just to make sure, let's scan their brain, make sure there's not something else that's encroaching on their memory center. But for the most part, if you have a family member there, you get a good clinical history. You don't really have to do too much in these cases. This is just me detailing the scan and the physiology behind it, so I think I can spare you guys of that. And then just a couple more other points in terms of things that we just really commonly see in the clinic or in the emergency room. Stroke sequelae. So when you have a stroke, if you have a So you're going to have symptoms that are going to be localized to the area of the stroke. So whatever that portion of the brain controls, right? And again, similar to when we talked about recrudescence at the beginning of the talk, sometimes those symptoms are going to fluctuate a little bit, especially in the earlier days. You know, a hard therapy session later at night, we wake you up all night doing neuro checks. Sometimes those little things can cause little fluctuations, kind of like a mild version of the recrudescence that we talked about. In the first few months, on average, 6 months to a year, but some of it is going to depend on how healthy that person's brain is and the size of their stroke. A lot of patients will complain of cognitive fog, just generalized fatigue. They do a 2-hour therapy session and they're wiped and they want to go to bed at 8 o'clock. That's normal. I relate it back to the example I give is you have a kid that's 8 years old and he's sleeping all the time because he's growing, right? Your other parts of your brain are trying to pick up slack from these damaged areas that they've never had to cover before. So you're exhausted. But other than these little fluctuations or an overall stability or improvement, you shouldn't have worsening of symptoms. Unless you're continuing to have more strokes, your stroke should have done the damage when it happened and then should be stable to improving as time goes on. So anybody that's coming back in saying their stroke symptoms are worsening, bells should be going off that you need to be looking for other things because strokes don't just progress. Like I said, fatigue, cognitive fog tends to be about 6 months. Altered mental status is another thing that comes up. If your patient, if your patient is altered and is borderline comatose and not really doing much, unless you had a huge stroke or a stroke that affected your language area to the extent that they don't know how to communicate with you, or you hit both thalami and your wakefulness center is messed up, then most of the time, all of those cognitive symptoms should be improving. This is a very dramatic example, but one of these can give you altered mental status. The other small dots won't. And so while you can still have a little bit of cognitive fog, a lot of times what we see is people will say, oh, the patient had a stroke, that's why they're altered, when a lot of times the image looks like this, and it may be causing some symptoms, but it's not enough to explain that altered mentation. So this is here just to say don't fixate just on the fact that the patient had a stroke. Look at the picture and see what's the extent of that. Does it make sense? And then this will be my last one. The other ones I did say were bonus. But who needs follow-up in these patients? So a lot of people will send us patients and say, oh, well, this patient had a stroke and they got lost to follow-up with their neurologist. They need to come see you. Not all patients actually need to long-term follow with a neurologist. It kind of depends. And so there are certain situations. What you really want to make sure is, number one, that the patient has a really good primary care doctor. And then again, we're here to kind of figure out what caused this, what medication changes can we make, what other tests do we need to do to figure out all of these causes. Once we get those causes, if it's something that we're going to follow, if it's something like there's a moya-moya differentiation here, if it's something like moya-moya disease or CAA that I think is going to progress, I'm going to see those patients forever. If I am the one that catches AFib on a heart monitor and we put the patient on anticoagulation and they never stroke again and their symptoms improve, then the idea is eventually that all of the specialists fall off and that patient can go back to normal life where they check in with their primary care who refills all of their medications, and we go from there. So unless there's changes in symptoms or something specifically that we're following that's more complex, you don't have to get an MRI and see a neurologist every 6 months. Some of that is just filling up the clinics and wasting those patients' time. So if it's something that is medical that we've figured out what the right medication regimen is for them, then we see them a few times and send them back, hopefully with a good plan. Some of these more complex things on the other side, we follow long-term. And these I knew I wouldn't get to, but I put just in case. And that's it. I'll take questions. Or not. It was just that clear. Okay. All right. Thank you, guys. Okay.